What physical therapists need to know about the meniscus? What's going on, guys? This is Dan Pope and Kevin Coughlin. We are physical therapists from Champion PT and Performance. We're here, as always, going through the medical literature, taking out all the important points and sharing it with you, putting in our practical experience in there, and hopefully just really teaching to be a better clinician. How's it going here today, Kevin?
It's going well. I'm excited for this one, Dan. I think if our listeners work in a sports setting or an active setting, this is definitely an injury they see a lot of. So, kind of getting this good background information about the meniscus, and we'll have a whole series coming up on what to look for from a clinical exam, how to treat it, and all that kind of stuff. So, I think we'll kick it off with a little background info.
Yeah, I'm pumped too. Personally, having kind of graduated PT school and then not knowing a ton about the meniscus, but being educated about it, as I learned more, I kind of realized how much I didn't know. And a lot of this information was really helpful, particularly from a practical perspective too, because information will probably change the way you treat your patients, which is good.
All right. So just kicking it off with some little bit of background on the anatomy without trying to get too long-winded here. So you have two meniscus. You have the medial and lateral. The medial is more C-shaped, and it covers about 60% of the articular surface. And it shares fibers with the MCL, which is pretty interesting. So that does make it a little less mobile because it has that attachment to the MCL. Medial meniscus tears, we'll get into what populations are affected by each kind of tear, but medial meniscus tears tend to be more common in older folks. So we do see these more often as that kind of chronic degenerative type meniscus tear. And then the rate of medial meniscus tears, given that they do increase with time, we don't see that so much with the lateral meniscus. And, we'll talk about this, but maybe some of that has to do a little bit with the anatomy. Some of it has to do with the mechanism of injury and that kind of thing. Lateral meniscus tears, they're more half circular in shape. They cover about 80% of the articular surface. So there's quite a bit of joint contact there between the femur and the lateral meniscus. The anterior horn blends with the ACL. So we'll talk about this because we see that lateral meniscus tears are more commonly associated with ACL tears. So when we get into that, we'll discuss that. Lateral meniscus tears are more common in younger athletes. So where the medial meniscus seems to be more of that kind of chronic degenerative tear, the lateral meniscus is more common in the ACL population and in traumatic injuries generally. And then just a little bit about what it's composed of: 72% water, and then there's a lot of collagen, type 1 mainly, and then some other glycoproteins as well.
Hey, yo, I've got something for you. It is an evidence-based cheat sheet on meniscus pathology. And I get it. Stay on top of literature for all the pathologies are coming out. Very tough as a physical therapist. Well, I'm going to try to simplify it for you. I've taken all the relevant information about the meniscus and jammed it all together into a cheat sheet. And my promise to you is I'm going to catch you up to date on meniscus pathology in under 10 minutes. In the cheat sheet, we go over mechanisms of injury, prevalence, acute injuries versus chronic injuries, anatomy of the meniscus, examination, types of meniscus tears, surgery versus physical therapy, and some rehabilitation principles for you. So I'll leave a link in the show notes in the description below. This is 100% free. Go ahead and click on that link, download it, and get learning. Now back to your video. Good stuff there, Kevin. Excited to kind of learn some more about the meniscus. One of the things I just want to plant in the listeners' heads is that little note about the lateral meniscus. And I'm not necessarily going to cover this too much today, but that becomes particularly problematic because of the interventions we have for the lateral meniscus, sometimes not the best from a surgical perspective. I think we were talking before the podcast that I think both Kevin and I kind of thought that athletes had more medial meniscus injuries just because sometimes they're coupled with ACL injuries. But turns out that's not true, huh?
Not quite. All right. So a little more focused on the anatomy here. The meniscus, crescent-shaped wedges of fibrocartilage, and it has that circumferential orientation. And this allows it to counteract compressive forces. It transmits forces towards the anterior and posterior horn attachments. And then you'll hear something called the hoop strain. So the hoop strain is really just a property of the meniscus that allows it to dissipate forces. And we see that different types of meniscus tears kind of maintain the hoop strain function, and some don't. And that kind of gives us some indication of who might be a better candidate for surgery, depending on the location of the tear, which we'll talk about. But that hoop strain, it's an important function of the meniscus. And in terms of healing ability, the next slide will have kind of a good visual on this, but the peripheral part of the meniscus, so that outer, 10 to 30%, that outer third, tends to have more vascular blood supply, and that allows it to heal a little bit better. Versus we see the kind of middle third, we call that the red white zone. Again, the next slide will have a good image on this, but and then that inner third really doesn't get a good blood supply at all and doesn't do a good job of healing. So, we'll see how that relates to deciding who and who shouldn't get surgery. But yeah, so a little bit there about the anatomy.
Yeah, just a quick note about the hoop strain that Ken was just talking about. So, hoop strain is sometimes maintained with certain meniscus tears and sometimes not, depending on the tear. And we'll get more into this. Also becomes very important from a rehab perspective. So if the hoop strain is maintained with a tear and repair, we could probably weight bear a little bit sooner, right? So there's one thing to think about. The other piece is that, and we'll get into some of this a little bit later, is that the location of the tear will dictate whether or not you can get a surgery to repair it. And the other thing is it dictates spontaneous healing, because that does happen as well for some patients. So if you tear your meniscus, does it actually heal without surgery? More on this later.
All right. Well, yeah, here's a great image just showing the different zones of the meniscus because, I'm sure we all learned about this in school a little bit. And it's definitely something that, a lot of people are familiar with. But I think a good review is that we have the red, the red, white, and the white zones. And that's kind of just going from the outside, working your way inside. And it's showing which zones get a good blood supply and which zones don't. So, as you had just mentioned, Dan, sometimes we do get spontaneous healing. And perhaps if that's in the most periphery of the meniscus where you're getting that red zone with good blood supply, sometimes that's where we get the spontaneous healing. Versus if we work our way in, we don't get good blood supply and we don't get necessarily a spontaneous healing. Sometimes in those folks, the white zone, we do see that as the worst area for healing. And they may be a surgical candidate in terms of having a meniscectomy, but maybe not a repair. And this is something that will be important to figure out. And that's something that the imaging will be able to tell us.
What do you think of this image here, Kevin?
That looks like a custom fitness pain-free image. I really like that image.
Yeah, it's a copyright-free image, and I was able to edit it via Fitness Pain Free, Microsoft Paint. Just kidding. I
Very
don't think it
good.
was, but that was my best artistic rendition of the meniscus zones of healing.
Did a good job.
Thank you.
All right. And now getting into the function, we did talk about how the meniscus is really its primary function is to transmission load throughout the joint and for shock absorption. So it improves the joint congruency and acts as a secondary stabilizer with the ligaments in the knee. And this is important for function and important for kind of dissipating stress and making sure that it's not located too much in one area. And we do see that being a problem when people end up having a meniscectomy. And there's definitely a big correlation between the size of the meniscectomy and the amount of force that's going to be going to that area in the future that leads to things like arthritis, which we'll talk about. But there was this study that looked at a 10-year follow-up after a meniscectomy. And we do see some joint space narrowing, 22% on the medial side and 38% on the lateral side. And then with the 20-year follow-up, this ended up leading to 56% rate of knee arthritis for the lateral meniscectomies. And we were talking about this a little earlier on before we started the podcast as well, but it does seem like the lateral meniscus, I think you'll explain this better than me, but because of the joint congruency in the knee, when it's no longer there and it can't absorb force as well, we see more kind of wear and tear of the cartilage in the bone.
Yeah, for sure. And again, I'll talk about this a bit later, but if you think about the lateral versus the medial tibiofemoral joint, so if you split it into left versus right, you have the medial and the lateral meniscus. The medial side is more congruent from a bony perspective. The lateral side relies more on the meniscus for congruency. So if you have a tear of the lateral meniscus, that's going to lead to more osteoarthritis, potentially worse outcomes compared to medial meniscus injuries.
All right. Now moving on to prevalence. So who's getting meniscal tears? It's a very commonly occurring musculoskeletal injury, and it does occur across all age groups and functional groups. There is a group of people where it can be asymptomatic, and then we do see a difference between chronic degenerative over time and more traumatic. And like we had talked about a little bit earlier, the medial meniscus seems to be affected by the chronic wear and tear type situation. We see that in older folks. And then the younger folks tend to have a meniscus injury, generally of the lateral meniscus, following some type of traumatic incident. The mean annual incidence, so how often is this occurring? It's estimated to be as high as 60 to 70 per 100,000 knee injuries. A 5-year cohort study showed that 5.1 meniscal tears occur with 100,000 athlete exposures in high school athletes. So this is a fairly common injury that we'll see in the knee, especially in younger folks that have a traumatic knee injury, definitely.
Yeah. And what I will say too is that not as common as your patellofemoral pain, but we do end up seeing it a lot. And I think the other part is that it's a tougher injury, I think, to deal with than your classic patellofemoral pain and often requires surgery, which is going to take a long time to rehab. So as a physical therapist, maybe it's not as common as some of these other pathologies, but you see it quite a bit. And these patients tend to stick around for a long period of time because of how long it takes to rehab.
So then if we look kind of like broad view, what population is at the highest risk? And I think this definitely depends because if your younger folks that you might see after an injury in sport, that's one population. But just generally, the chronic degenerative meniscal tears are more common. And we see these mostly in men greater than the age of 50 years old. They tend to have a higher BMI, but that's not always the case. We do see this in folks with a chronic ACL laxity. So, we'll talk about this. There's some interesting research showing that if this is different than chronic laxity, but if you do have an ACL tear and you wait to get it reconstructed, we see higher rates of meniscal damage in that period. So, having good functioning ligaments in the knee seems to protect the meniscus. So if we do see kind of that chronic ACL laxity, we have more damage to the meniscus, and that's something important to keep in mind. So you might want to, even though if you're considering this is a meniscus tear, we'll talk about diagnosis, but you might want to check the laxity of the other ligaments in the knee as well. Kind of can help your decision making. We also see this occur. So, I would think of it the older gentleman or lady who maybe had an active job throughout their career that required them to do frequent bouts of squatting or kneeling and lifting. Um, that mechanical load on the knee seems to predispose people to meniscus injury over time. And then in that population, we see kind of a rate of 8.27 per 1,000 person years. And those are always confusing, but I think, yeah, interesting numbers just to think about. So that's probably the population that we see at highest risk of this. So, maybe that age where we're thinking they might have some knee OA, but maybe there's something else going on in the knee as well.
Mhm. Yeah, one things I just note on a little bit is that you will see higher rates of meniscus injury and also subsequent OA in a lot of sporting populations, as well as manual laborers, or people who spend a lot of time in the bottom of the squat. And in the social media world, there's a thought that like activity is good, and it is. Of course, activity is definitely great, but you spend a ton of time kneeling, laboring, spending time in a squatting position. That does tend to lead to more symptomatic issues over the course of time, too, right? So it's probably a sweet spot in terms of exercise and activity. We want to try to push our patients too. And you will see a greater likelihood of folks having meniscus pathology if they're working manual labor, especially if they're kneeling, squatting, so on and so forth. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really, my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So, it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the fitness pain-free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
Yeah, you're right. It's always nuanced, right? It's never so simple, unfortunately. So yeah, just a little bit about, we just talked about this, but we see the higher rates of the meniscus pathology as well in sporting populations. This tends to be your younger folks generally. It's an acute meniscal tear. Sports that require running and cutting definitely are going to be the culprits here. So we could think about, soccer, rugby, American football, basketball, baseball, skiing, sports that really require that you're changing direction, perhaps with a slightly bent knee. That seems to be a mechanism similar to our ACL tears. And then, like I had mentioned before, people with ACL deficient knees, so they're more at risk for development of, so I guess chronically, they're more at risk of development of a medial meniscus tear versus that acute ACL tear. You're more likely to see a lateral meniscus tear, especially if the ACL is the reconstruction is delayed. So if you wait a long time to get your ACL reconstructed, maybe you have good reason to do that, but you just know that there is a chance that the meniscus is going to be suffering from a little bit more stress, and that may or may not be an issue long term. And that's potentially a reason why reconstruction is often the choice following an ACL tear, not just to return to sport, but to protect your knee long term. It's probably better for the long term health of your knee. But that's interesting too, right? Because sometimes we do see higher rates of knee OA in people who have had ACL reconstruction. So that's, I guess, just don't injure your knee in the first place. Maybe is the best alternative there. And then just like I had mentioned, so just to keep reiterating this, your acute ACL tears, you're more likely to see damage to the lateral meniscus. And there was a study that was looking at this, and 66.7% of ACL tears were associated with a lateral meniscus injury versus only 4.6 were associated with a medial meniscus injury. So just something to keep in mind when you're assessing your ACL patients.
Mm-hmm. I'll try to be quick here because this is going to derail us a little bit. But just a little bit more information about the whole, when you get your ACL reconstructed, you're more likely to have osteoarthritis compared to not, right? And I'm sure we'll go in depth on some of this research in our ACL talks later. But yeah, that's odd, right? It's like, okay, well, if I repair my ACL or reconstruct my ACL, sorry, should have less incidents. Maybe that's because we're getting back to sport more so after ACL reconstruction. If you don't have reconstructed, maybe don't do quite as much. It's funny because I'm always very leery of dentists, right? And I had 4 cavities last time I went. I'm like, what the heck am I doing to give myself a bunch of cavities? And I was looking at coffee because I just drink a ton of coffee, and coffee can reduce the amount of enamel on your teeth, right? And the thought is that drink a lot of coffee, you'll have less enamel, right? More cavities. But if you look at research on coffee consumption, it seems like coffee is actually protective against cavities.
Hmm.
Doesn't make any sense. But I thought that was similar to the meniscus and ACL research, right? It's like
That's a great
not
parallel.
counterintuitive, but sometimes
Yeah.
that's what you see. Yeah. All right.
Coffee's worth it, no matter what the negative effects are.
Oh God, I love
So
the
worth
caffeine.
it.
Yeah.
Yeah. All right, and then just talking about the mechanism of injury. So how is this occurring? We did mention this a little bit, but acutely we see a rotational and shearing force causing the meniscus tear. Generally, a twisting on your knee. So cutting, pivoting, jumping, changing direction, rapid acceleration and deceleration. Definitely worse when we add axial load to that. Added speed, added weight. We're going to see more force through the meniscus. Can definitely cause a tear. Conversely, that chronic wear and tear, typically this is due to repetitive stress on a failing tissue, subject to high physical loads, and in the context of metabolic risk factors with little or no trauma. So, like a lot of different things, we do see, unfortunately, for our kind of less healthy folks, perhaps they had a career in manual labor and then they have some metabolic risk factors. We do see that chronic wear and tear of the meniscus. We talked about if you're working a job that requires a lot of kneeling, squatting, lifting, carrying heavy weights, that you're a little bit more likely to get a meniscus tear that way. And then, like you had said, sports are amazing. We want everybody to be active, but we do see that on the extreme ends of sport, ex professional soccer players or runners who are running, high double digit, maybe into triple digit miles per week. These folks over time tend to have a chronic injury to the meniscus. So, yeah, just something to consider. All right, now getting into the types of meniscus tears. Uh, this was very interesting to read about because I think I used to way oversimplify it in my head. And there's a lot of different types of meniscus tears, and they're definitely, uh, it's good to be aware of these. And obviously, if you refer your patient to a orthopedic doc, they can help figure this out. But it's good to have this background. It's important to know, as Dana talked about, some of these maintain that hoop stress. It keeps it intact, and it might show who could be a better candidate for a non-op or an op. So just something to keep in mind. But there are a lot of different types of tears. And this little infographic on the side is pretty nice. It shows some of the ones that I'm going to be talking about, just so you can have a visual in your head. But the first type is a peripheral tear. So there's no picture for this one, but if you think about that crescent C shape and you're looking at the convex side of that C shape, we tend to have, that's where a peripheral tear can occur, a little tear on the outside of the meniscus there. This is that area that tends to have good blood supply. So peripheral tears often do pretty well. It may show some spontaneous healing. That may be something that the surgeon will determine if it's something that they should operate on or not. But that's one type of tear, a peripheral tear on the outer edge. Another type of tear is a vertical tear. So these are commonly associated with trauma, like in our ACL folks. This type of tear runs parallel to the meniscus fibers, and it can either be stable or unstable. It can lead to a bucket handle tear if it's large enough. And what a bucket handle tear is when a flap of the tear ends up coming up into the joint space, and it can lead to clicking or catching in the knee. So we'll talk about that a little bit more, but something to be aware of. But the vertical tear, because the tear is parallel to the fibers of the meniscus, it allows for an intact hoop stress so that the meniscus can still dissipate forces pretty well. depending on what zone that's in, is where the surgeon may consider to operate or not operate. A third type of tear is a radial or a transverse tear. So if you think about the peripheral tear, which I had mentioned, that's on like the C shape on the back of it. So on the convex side, this would be more on that concave on the inside of the C shape. And this is more common in lateral meniscal tears. It extends from the inner margin of the meniscus outward. We do see in this a type of tear of this is a parrot beak tear. I think that's my favorite kind of tear. It's a nice word.
Yeah.
And this type of tear, because it's perpendicular to that hoop stress, perpendicular to the fibers in the meniscus, it can disrupt the hoop stress mechanism. So we see a little bit of issue with how well the meniscus can dissipate forces. So there are more, but those are the first three that we'll introduce you to.
Cool. Sorry, I won't take up too much. I know you're in the middle of the topic here. I just want to say just how important this tear types actually are, and this is something I had no appreciation for right out of PT school. But the tear type is so important, right? It could be more of an anterior tear versus a posterior tear, which can influence your exercise selection and also protection after an injury, after a surgery. Could be more medial versus lateral. We know that certain exercises strain the lateral versus the medial more. We know that the medial is more strained in deeper degrees of knee flexion. Obviously, there's different types of tears. If it's in more of the white or red-white zone, doesn't heal as well, so maybe you have to go a little bit more slowly. You also have root tears. There's so many different types of tears to appreciate. And if you understand the different types of tears and some of the things that Kevin's explaining, it's going to allow you to just be better at critical reasoning and having your patient make the right decision from the standpoint of whether or not to go to the doctor in the first place and then how to rehab them as well. So just super important.
Yeah, it's definitely a good point. It's always important to zoom out and think like, how does this apply to what I'm going to be doing with the patient? And it definitely has a huge impact, like you had said, even if it's early on before surgery, just symptom management, like what exercises to avoid if you have an anterior meniscus tear. Maybe we'll stay away from our TKEs and stuff like that. And I know you'll talk about that when we get into treatment, but yeah, just important to remember. Uh, so a fourth type of tear, and there's more than I think I'm going to cover, but I'm trying to cover the big ones that we see in the research. So a horizontal tear, this is also called a cleavage tear. Uh, I actually lied. This might be my favorite one. I think
Whoa.
it's so interesting. It splits the meniscus perpendicular to the fibers. So if you were to look at, the meniscus from the side, it kind of splits it in half. So it's like two pieces of bread stacked on top of each other. That's just how I thought about it. This can also lead to a bucket handle tear. So we can get a flap that goes up into the joint space and can cause a lot of those mechanical symptoms. Or, if that doesn't happen, it can be asymptomatic. This is more likely to occur in older folks without trauma. So we do see this as more of that degenerative and chronic meniscus tear. And this does impact the force absorption. So, we don't maintain as good hoop stress in this type of scenario. The fifth one, and probably the most, uh, the one that will impair you the most, is a complex tear. So this is just where we see that there's multiple tear patterns. Maybe somebody has a transverse tear, a peripheral tear, and some degeneration. So any combination of tears we see as a complex tear. And this severely disrupts the function of the meniscus, and it causes that kind of uneven load distribution, which we talked about can predispose somebody to arthritis. It may, where they're complex, they could be in different areas of the meniscus. Certainly, some of those areas won't have good blood supply. So, that's a fifth type, and probably, it's a combination of a few different types of tears, and it's pretty common, unfortunately. I think, especially in the chronic kind of degenerative meniscal tears.
Just to kind of shed some light into the surgeon's job when they have a patient come in. So you think about that horizontal tear, tends to go across different zones of healing, right? So let's say it starts in the white, then red-white, and then goes into that red-red. You can kind of appreciate that maybe part of that will heal kind of well, but other parts not so much. And it's funny from a history perspective. We used to think that these horizontal cleavage tears didn't really do well repairing, and some of the early research showed that. But one of the things we're finding is that it's so important to repair the meniscus whenever you can. There's some of the newer research, and I see a lot of surgeons do this, is that they just try to repair it. And it turns out that oftentimes these can be successful too. But that's going on in the surgeon's mind is like, should we repair this? Should we resect it? What's the best course of action? And the other piece that happens sometimes from a surgical perspective, particularly with like a complex tear, with a complex tear, there's kind of multiple different types of tears going on. The surgeon has to figure out what should be repaired versus resected. And sometimes you'll find that part of the meniscus is repaired and other parts of the meniscus are resected, right? And I'm just kind of thinking back to a patient of mine that had a complex tear as a younger athlete, soccer player, and they ended up repairing what they could and resecting the rest, right? Because the idea is they're trying to save as much meniscus as possible. And even if they have to resect some of it, they resect as little as possible to make that repair, or at least the meniscus, stable at that point, right? Obviously, if they repair that, they want to repair some of it and resect some of it, but they want the resected element to be stable. But they want to leave as much as possible because we need our meniscus.
All right. And then kind of a sixth type of tear here is a degenerative tear. Again, this could be, like I said, part of a complex tear. We do see it in that type of tear, but this is the gradual onset commonly seen in older adults. It compromises the hoop stress, which causes uneven wear throughout the knee joint and increases your risk of osteoarthritis. So oftentimes this is on that concave part of the meniscus, so kind of on the inside part, and it does bleed into the rest of the meniscus depending on the amount of degeneration. So you'll see a little bit different type of tear with that, so it does get its own category.
It's good to be in a degenerative.
Oh yeah.
Okay.
Oh yeah. And then so the prevalence of degenerative tears. So we see this increase with age. So between the ages of 50 and 59, roughly a 25% prevalence. Between the ages of 60 and 69, a 35% prevalence. Between the ages of 70 and 79, 45% prevalence. But then in patients with diagnosed knee osteoarthritis, it's as high as 75 to 95%. So, that's just super high. That's kind of wild. And then prevalence of articular cartilage lesions in athletes ranges from 17 to 59%. So pretty big range there. But I think the thing to keep in mind is if you have some untreated tear of the meniscus that degenerates a little bit over time, leads to more knee arthritis, and it can lead to articular cartilage damage, which would be something we definitely want to avoid. The incidence rate is high after a partial meniscectomy or a secondary ACL injury. So, like Dan had just said, we want to keep as much of the meniscus intact as we can. If that means a surgeon goes into a complex tear and repairs some of it, they're going to repair hopefully as much as they can, because that part of the meniscus that we do take out during a meniscectomy can lead to higher rates of these things like degeneration, arthritis, and potentially a cartilage damage. So just something to keep in mind.
Yeah, I think we'll also say that a lot of these meniscal tears are asymptomatic too. So obviously these numbers are really high, and just like a lot of other conditions in our body, it doesn't necessarily mean that you have pain, although you certainly can, right? Oh, also, what I want to say is that just by the definition of a degenerative meniscal tear, it also means that you have osteoarthritis, right? And then osteoarthritis, we know, is a total joint disease. Things like joint space narrowing don't often have a good correlation with pain, right? So if you have degenerative changes to meniscus, that by definition would be called knee osteoarthritis, unfortunately, and that does tend to occur earlier in life, and obviously it can get worse over the course of time. So now you just learned a ton about the meniscus. Let's say you have a patient in front of you and you don't know what to do. Well, you probably need to know some exercises to help folks that have knee meniscus injuries. And above Kevin's head, right over here, over there, I'm going to leave a link. We'll go over my favorite beginner exercises for patients with knee pain, also patients with meniscus injuries. So go ahead and click on that link, and I'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So, Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step by step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I add to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.